Right. Hi, everybody. Welcome to the
So we'll get
second day. We're gonna
started.
get
David is our moderator, and Joyce Tang, Dr. Joyce Tang, is our first speaker.
Great. Thanks. Thanks, everyone. Let me just say a few words. First of all, thanks again, everyone, for coming, and thanks for a great day yesterday. We lost one or two people because they weren't feeling well. So that's too bad. So your hands and keep it here, that sort of stuff. Use the spoon when you eat the yogurt. Anyway, I thought yesterday was just a great day. I learned a ton, and I came out of it both confirming some things that I hope I would confirm, and also learning some things that I hadn't anticipated. I hope that's true for many of you as well. And I think this is going to be an exciting day today as we think about what collectively we've accomplished in the past year and brought to the conference, and then also think about what we do going forward. But I think the sort of theme of what going forward looks like is a perfect sort of transition to the session, which is really about preparing the pipeline for physicians in comprehensive care programs. We actually, when we started thinking about this session, we weren't planning just to limit it to physicians. But then as we realized sort of how much there was to talk about, we just realized we couldn't do it all. And so I really want to emphasize that, as critical as physicians are, of course, in all of this. This is obviously a team, and I know that's part of the training that we're going to hear about today. So I'm really excited for these conversations. I know a little bit about what everyone's talking about, and there's a lot of exciting stuff to hear about. So let's begin. Joyce first.
Great. So I'm impressed by how many people are here so early in the morning. So thank you for being here. My name is Joyce Tang. I'm from U of C, one of the comprehensive care physicians. So just a couple of things we're going to talk about this morning. So some of the critical skills I think that need to be developed in overcoming some dogma that exists that might be along the way. Our journey, some lessons at the U of C, and finally ending with some implementation considerations. So what are these dogmas that I'm talking about? So the first is a little bit about how we care for patients in this traditional H&P model that is very biomedically focused, and so may not be the best approach for thinking about patients holistically the way that all of us do. Second, how we care for ourselves. So this work is hard, right? It's challenging. And I think that to endure and be able to continue to do this work well, we need to think about perhaps the systems we have in place for traditionally caring for ourselves, which is yoga, meditation outside of the work environment, is not working so well to sustain this type of practice. And third, a little bit about our clinical learning environment. So we traditionally have these traditional block rotations, and is this the best model for demonstrating longitudinal relationships in care and the types of learning from patients over time that we think is important? So first, talking about that traditional H&P. So I think, we've had this around for a really long time, and you might think it's not so controversial. But the fact is that the H&P is how physicians define what's important, right? What do they focus on? What's on the problem list? Why is a patient coming in? So we're not digging deeper into understanding what's behind that exacerbation of the chronic illness. If we're not thinking about how they're going to manage their condition when they get home, then we probably have a problem there. I don't need to tell you guys this. You know that 80% of well-being relates to things outside of healthcare. But why does our traditional H&P still have 90% biomedical information? That seems like a problem. So again, I kind of hammered in on this implicit focus on acute care, the biomedical model. And I think it's not just that we define problems differently when we think about it in this way, but we define the role of the physician very differently when we kind of have this as a lens of what we see problems to be, and how can this be reconceptualized for practicing in this 21st century? So I'm going to argue that perhaps we should think about it in terms of 7 domains of health that are comprehensive and universal across all practice of medicine. This should include the patient's values, goals, and priorities. We don't ask about that enough. We should have mental health pretty upfront. We should be thinking about the social context in much greater depth, not just the report of the tobacco, alcohol, and drug use that often it becomes limited to in the clinical setting, right? We should dig in about behavioral health, the living environment, resources, function, the social support. I think all of us understand the importance of that here. And I think that's really key to building patient engagement, self-efficacy, and improved chronic disease management. So these domains could be inserted within the traditional H&P model in this way. So a couple components within the HPI section, and then that really robust social history. And I think that's important to be a piece of everybody's learning experience within medical education as they move forward. We have implemented this model within a variety of contexts. So we've actually implemented it across the spectrum of learners, M1 through M4, across outpatient settings, virtual settings when we were making COVID follow-up phone calls and the residents and students were not in the clinical environment practicing as much. The inpatient setting for our post-clerkship students. And then most recently, some of the folks here, including Andrew Sham there in the back, is involved with this visit program that's been really wonderful in integrating this model and pairing it with an interprofessional team intervention. We have integrated this into a doc phrase within Epic to make it part of the usual flow of care. And we've surveyed students to understand when we do this, what do they think about it? Is it possible? Is it feasible? And so what they think is actually, it adds really valuable information. It helps them understand a patient's goals. It builds that stronger relationship. But what you also see here is that the levels of facilitating interdisciplinary care planning are a little bit lower. And I think that's really important to note that if we ask students to do this, but we don't pair it with a robust interprofessional intervention, they're going to be disappointed, right? They're going to identify problems that they say, I can't fix, and that's going to feel bad. And I think that if we don't prepare our learners with that robust paired intervention of being able to do something about it, we're going to lose them. And that's a problem. So unfortunately, grappling with these difficult issues of health-related social needs does increase the rate of physician burnout. This study was just in December of 2024. And I think all of us realize this is really, really hard work. So as we think about asking our learners to do more in this domain, we also have to think about, are we preparing them to actually be resilient, to be able to thrive in this kind of environment? So Nicole Gear from CCP shared a little bit yesterday about our complex care rounds, and I think that model is a really unique model and should be something we think about when we think about how can we better integrate within our workplace and workday environment, these structures to think about and reflect on our feelings, the challenges, and this should be a kind of a typical day that we integrate these reflections into our practice. We know that traditional wellness programs are limited, okay? They're outside of, they're additive to regular work hours. It requires you to be individually motivated. So no surprise, people don't go, right? Because they're busy. They have other things to do. And so outcomes are really mixed. Benefits are limited and difficult to sustain. And I just have this up here just to remind us that we can actually learn from other types of models. So DBT, dialectical behavior therapy, developed by Mark Linehan, actually has a component of care, not just focused on patients, but focused on the team members, saying that in order to do this work, we need to have some type of skill building and supports and time to reflect for the clinicians in the program, because we know that that's important to build capacity and to build their motivation and capability. This might look familiar from yesterday, Nicole shared this, but we should think about how can we integrate daily into our practice, not just reflecting on patient needs, but also what's coming up for us, right? What are those emotions? How can our team better support us? How can we talk about this productively? So we studied a little bit about how participation in complex care rounds affected participants, clinical providers. And so we had them write reflective essays on the impact of participation on their daily practice and on their work with others. And this is what we found. This is a conceptual model that we developed based on the research that we did. So these shared team frameworks gave rise to a practice of self-compassion and also fostered a really validating team environment that as a whole worked together to synergize and improve patient care. So it built capacity, it built skills, and provided greater ideas for patient care from a very interprofessional, broad focus. There's too many wonderful quotes to share. So I just picked one that is from a trainee that participated in CCR. And so this is what they said. At CCR, the team openly discussed challenges and also difficult emotions such as shame, frustration, failure, and sadness that are often hidden in a clinical context. At CCR, it was especially powerful to hear about these experiences from people who are respected so much and acknowledge that these are normal human emotions and health. So really powerful, kind of reflecting on that role modeling that we can provide for our trainees in each of our unique environments. So because not everybody can rotate through our CCP rotation, we're kind of a small program, we tried to broaden the skill building to other students. So for our first year and second year learners, we offer, Nicole and I do a workshop for the students that focuses on a little bit on that DBT type skill building, those types of agreements that she talked about a little bit yesterday, and principles of self-compassion as well. And so we integrate the skill building workshop and had them also reflect on how they can use self-compassion after a specific exercise. So all students are going through these OSCEs, right? Observed, structured, clinical encounters. And so we have some that are really challenging. They're reflecting on giving difficult news to patients or counseling about interpersonal violence. And after these, this can be really emotional encounters for them. And so we ask them to reflect on how can you integrate self-compassion for yourself after participating in this activity. And so this is a quote from a student who did just that. So I should remind myself that not everyone is ready to share vulnerable information about themselves, and that there are times I felt the same way too. It's okay if they're not ready to open up at the moment if I find myself struggling. So lastly, I want to talk a little bit about that clinical learning environment and how that shapes what students take away to be important. And so these traditional block rotations are like 4, 6, 8 weeks where you get immersed within, say, internal medicine, pediatrics, psychiatry. And that's a really great approach to learn about a specific type of model of practice for a specific population. But it's not so great for building those longitudinal relationships. It's not great for knowing what happens over time with a patient. And building that understanding, I think, is really key, as well as understanding the joys of caring for someone over time. So how can we change that? So the Longitude Integrated Clerkship some programs have, I think, is a wonderful model. It's also been really difficult to scale because they're so challenging and large in scope. So one idea would be to do this within the pre-clerkship time. We have our program at Pritzker where we pair students with patients, a handful of patients who they follow longitudinally over the course of the year. And then we randomize, or did at one point when we're studying this, we randomize students to either that model versus that traditional preceptorship model, where they're paired with a clinician and see a bunch of patients within that individual preceptor's clinic, rather than following a patient across a lot of different environments. So apparently it matters, what type of experience you have, because the domains of learning really differ. So whereas those students in the traditional model talked about biomedical learning, I learned about this disease, I learned about how to do a physical exam. The patient-centered track students talked about it was really hard seeing, how they were managing their disease, how they were navigating the healthcare system. They spoke of the patient as the teacher. And really learning through that lens, which I think was really powerful. They learned the importance of building a relationship. So I'm just going to end with this quote that one of our students discussing and reflecting on their experience in the program and what was said there. We were humbled that our longitudinal patient's mother shared her experiences with us, and grateful for her willingness to teach us about cystic fibrosis in her daughter. I believe the insights we gained will help us become empathic physicians, more attuned to patients as individuals and capable of practicing patient-centered care. So just a few implementation considerations. There's always competing curricular priorities. It's a crowded space. We need physician role models. I think all of you here today would be wonderful role models for this type of practice. As well, thinking about building that interprofessional practice environment to support the type of supports and the environment that's really going to foster students wanting to continue to do this work and feeling supported with it. And I'm just going to end there. Thank you.
For this time, I'm gonna be a little bit more philosophical than actual takeaways. I could probably talk about this for hours. I'm part of the faculty for the Interprofessional Collaborative at Vanderbilt, which is great. It's 13 half-day sessions throughout the year, and they're bringing in different multidisciplinary teams into the medical school. And I think a lot of when we talk about physician recruitment, I think you can find some core competencies that you can pull out from interprofessional collaboration that would make people be successful in being a part of this model. I also have just 2 books that I would recommend. One is Range by David Epstein, and it's talking about how a generalist can succeed in a subspecialized world. And I think the takeaways I've gotten from that book is really that sometimes when people are siloed in their frameworks, taking a step back and having people with just a generalist outlook can really tackle the problems of the workforce in whatever industry you're in. And the other one is Upstream by Dan Heath. I think that's just a general great problem solving. It's essentially like solving problems before they happen. So just 2 takeaways that you can read on your own time. And I think if you take away some of the themes from that book, you can gather the mindsets of physicians and other professionals that would succeed in a framework tackling the patient population. So I have a lot of questions. I don't have answers. And this is really thinking about the implementation of an interprofessional team to take care of the high and high cost population and a comprehensive care model. Whenever I've come up with this capacity of population and how you design the team, and this is the Vanderbilt FTE breakdown. So this might be useful for people who want to say, how quickly can I scale based on the resources I have? So it's a little bit of an algebra problem, but around 900 patients is equal to about 4.8 physician FTE with this administrative provider FTE to kind of keep the program running. And then there's this idea of like risk severity. We're all taking care of very complex patients, but it depends on how complex you are, whether you're looking at your CMI or in the Medicare population, you can use your RAF scores based on HCC conditions, which are more expansive in 2025. And you could use that as kind of a gestalt factor. I do think it's very important in how you design the team to work. And remember that we're primarily a rounder-based model. And the importance is that everyone works together in the same workroom on one unit with a consistent nursing staff. And what this does is it facilitates an interesting theory of thinking. So to apply a electrical circuit metaphor in traditional hospital medicine or even just care management, things happen in series, right? Like physician thinks, talks to case manager, talks to physician, actually we need a social worker. In great models that have daily multidisciplinary rounds, but everyone's coming to a huddle at 10:30 and everyone's working in different units, maybe you get some parallel based thinking, right? It's, people can work at things at the same time. But if you design the team in an interesting way and really co-locate the work environment, and I know this theme has come up, it's like birds flocking together to make majestic shapes. It's complex thinking, right? It's complex team-based thinking. And I really think that's the type of team-based support that is important to care for this population. So if you can think about the mindset and how you can structure the team, there's some things that you're going to want to know to know from a success standpoint, and that is, do you have executive stakeholder buy-in to give yourself time to design this model of care? And then you want to think about what determines success. At Wisconsin, you guys are doing your learning health systems trial. So you have a key defining of success. Is this feasible to do, right? At Vanderbilt, right now it's Success is, can you decrease length of stay, get patients out early, and care for them safely, and try and reduce readmissions? That is our success statement, and that's what we're working towards. And if we're not doing that, I could see that they blow up the whole mission and say, just take care of the patients. And the other thing that I think is so important is, how do you prove success? And you need some sort of data analyst or data gatherer, and how do you prepare that you can create those statements to your executive holders? So again, more questions. A lot of it also is, how do you start growth, and how do you subsidize the clinical workforce while ramping up the population? You could flip on, if you have the selection criteria and you have an algorithm that can identify patients, at Vanderbilt, I could turn on the lever and say, here's 3,000 patients in our population today, right? We don't have the capacity to do it. So we have to, and over time, we had to ramp up slowly to see, like, what is our capacity. I wish I would have included this data, but it wasn't really available. But I have VICP admissions over time from 2017. The patients in the population are about stable, but then I matched it with our population of enrollees that goes up. So you can make the case that over time, we're more efficient and effective at taking care of these patients, and we can increase our capacity. And that has a lot to do with the inner workings of the team-based unit. The other thing is, how do you manage turnover and hiring? That's tough. And I think this has a lot to do with identifying what are the core competencies of an individual to be able to succeed in a model like this. I think from a physician standpoint, there's some interesting mindsets of people who are dual trained, med peds, med psych. You can imagine even IM, EM trained physicians. There are people who inherently look outside the box of their general frameworks, going back to the original books that I talked about. I also think that you could pull some core competencies of people who are trained in the AMA-led Change MedEd Consortium in health system science. So there were initially like 31 schools, and they implemented a health system science education, of which part of the 6 core domains of health system science is team-based collaboration and care. And if you can find people who have exposure to that, great. There's even a Health System Science Academy. I did an inaugural version of it in residency before it was made national, and I found that illuminating to think about how the health system operates, to give you a core set of skills that you can then apply to this patient population. So if you can find people who understand the mindset of the health system, and it's interesting to give the health system a mind to operate in, these are the type of people you're looking for. And then you can apply this to any interprofessional training. I will briefly mention, I went to Allegheny College. I don't expect anyone to have ever heard of it. It's a small liberal arts college, but the slogan was unusual combinations. And the way the curriculum was designed is that you had to do a major in one field, a minor in another field, and have a set of courses in a third field. So I was a biochem major with a psych minor and a Shakespeare minor. So if you can find people that have exposure to solving problems but applying it from different industries and fields, I think those are core things to look at whenever you're hiring people. And this has a lot if there's this whole big website on interprofessional collaboration and education. You can find it just with a simple Google search. But from your interprofessionals and your physicians, how do you define team roles and responsibilities? How do you teach physicians to adopt a non-hierarchical way of thinking and promote the ideas of other interprofessionals to lead the team? How do you do this complex team decision-making? How do you facilitate that with your geography? How do you adopt a shared mental model? What are the structures in place that you can create? For example, I've heard a lot about the weekly huddles, but how are the weekly huddles designed? Who leads them? Is it the physician leading them? Is it the program manager? Is it the social worker? Is it everyone takes a turn? How do you structure how you communicate the patients, and then not only how do you communicate the patients, but how do you communicate about how a program is run. This is like having a board of directors who all have equity in a business, right? And how do each of you vote to create the mission of the group, right? That's what this is really about. And I do think it's important that every program has a mission and a value statement that they look at regularly and decide with the team on what that means for your local institution and how it aligns with the executive leadership and goals of this facility in which you work. That way you can make sure that there's alignment, that you're working towards the values of a place in which you work that has similar values, because then that has a synergy of growth. And I think the other thing is I love that word, arbitration of disagreement. Everyone's not always going to agree in this team model, right? So how do you implement a structure that people can have their input and opinions heard, and no one is shot down in a punitive way, and that you can come to an agreement. Another book, it's from Negotiating to Yes. I can't remember who the author is, but it's written by people from the Harvard Business School, and it talks about how you come to negotiations from all sorts of disciplines. Another good book. This is my drawing of how our team unit is designed. So I couldn't take pictures and make it work. Does this have a laser pointer? So in the bottom right there, what you can see is that's the hallway where there's 2 patient rooms, and that circle there is our work area. And then the big circle is the round wing unit with the nursing station in the middle. So that is how we functionally operate in the inpatient unit. And this is our workroom and where everyone sits. And it's a small room. There's Jane. But there's 8 workstations in this small space. And there was originally 5. And then that little chair where the trash can is, there's 8 times. So it's a small workroom, and there wasn't a lot of places for people to work, but we were adding a new pharmacist, and I thought, why does she have to work in a different place? She should work with our team. We also do welcome learners regularly, so we wanted a place for them to work so that they didn't have to go away from the team to work. So you should be able to find in your institution some sort of lean workplace engineer that can optimize your workspace. I thought Vanderbilt would have these people, and they don't exist. But I have a little bit of lean training, like Lean Six Sigma. So I actually did a workflow map, and I rearranged where everyone works so that I can optimize facilitation of the ambulatory providers and inpatient providers, and then enhance the communication of how everyone works, moving the inpatient care forward. So if you go back here in the circle here, the program manager, our advanced practitioner, our LPN are primarily the clinic group for the day. But our LPN used to sit over here, and then the APP used to sit over here, and I was here. So these 2 people, so this person over here, they were yelling across the room about things, interrupting this communication that was happening. So if you reorganize how people work in a methodical way, it actually can help facilitate communication, but also not interrupt the operational way that people. So just kind of my 2 cents. So that's all I have to say. I can share a lot of philosophy on how you design these teams and recruit people. So feel free to ask questions.
Great. Well, it's a privilege to be able to speak with you today. I think David asked me to share a bit about some plans for a new residency program that's being built and how we might be able to leverage this opportunity. I mean, it's rare to have a tabula rasa, to start a residency program from scratch. So how can we leverage some of the expertise in this room to help embed some of the principles of comprehensive care into the program from the very beginning? So let me start. Let me share a brief history of where this residency program will be built. It's going to be at Ingalls Hospital, which is a hospital that just recently acquired by University of Chicago. It's in the southwest side of Chicago. It was founded by an industrialist in 1923 in Harvey, Illinois. The original vision was that Mr. Ingalls wanted to provide healthcare services for his factory workers and their families. Hospitals kept alive through various economic downturns and then nearly single-handedly kept alive due to efforts of Mr. Ingalls' daughter. There's various FQHCs surrounding the hospital, with the one right next to the hospital, Family Christian Health Center, serving as the primary ambulatory site for the future family medicine residency program. Here are the demographics of the patient population in Harvey, as well as the demographics of the hospitalizations here. And you can kind of see, particularly here in the financial class, this is pretty much an underserved community. A lot of patients coming in with government insurance. A significant percentage of the neighborhood is living under poverty, below the poverty line. And you can kind of see the statistics here. Predominantly community of color. So why start an internal medicine residency program? I think the strengths is to invite learners into a dynamic, growing clinical and academic environment that prioritizes care for the underserved and promotes human flourishing for underserved communities. Some of the weaknesses of starting one is that the institutional culture of this particular hospital, it doesn't have any teaching trainees. So the culture is not accustomed to teaching, and there's some concerns that learners will, quote, slow me down and reduce clinical productivity. One of the major opportunities, however, is you get to build from scratch potentially a comprehensive care model that will be attractive enough during training to encourage trainees to practice in a patient-centered comprehensive care environment. But some of the threats to starting a program in this current political environment is that there might be reduced GME funding for new training programs in particular geographical locations designated as health professional shortage areas. And this will potentially depend on our new health and human services. This is the proposed mission statement here. I'll just read it. The residency training program at Ingalls comprehensively trains internists exhibiting the virtues necessary to practice medicine with practical wisdom and clinical excellence. Our internists pursue health for patients in underserved communities with an eye towards their holistic flourishing. And specifically, we seek to train internists who wisely discern how best to promote the health of patients with a broad awareness of how patients' bodily needs are related to their psychological, social, and spiritual concerns. This mission statement in some ways is informed by a human flourishing framework, which takes into account that there's more to flourishing than just biomedical health, as Joyce was sharing. Let me just share, and there's going to be a couple of tracks that we hope that, where residents will be able to pursue scholarly activity based on their interests on these 4 lines of community health and primary care, medical education leadership, health system science, and clinical and translational research. This is the proposed structure. You have about 16 categorical interns with some 5 prelim IM interns each year. Each of these category interns do have at least 10 months of clinical experience in the outpatient setting. So many of the things that our previous speaker was sharing about, you were just giving me a lot of food for thought on how to design a continuity clinic. And as I mentioned, the hospital leadership is exploring the idea of building their own IM residency continuity clinic, which could also serve as a urgent care walk-in clinic to help alleviate an overcrowded ER. Again, part of the reason that the hospital leadership is thinking about this is not necessarily for revenue generation, but potentially revenue saving, because many of these ambulatory patients are actually filling up the ER. But some of the my interest in this is actually the idea of promoting continuity of care. This is a study that that colleagues and I had done several years ago, where we were just wondering to what extent are actual physicians feeling, on the ground that having some sort of long-term relationship with continuity actually promotes care. And so here are some of the questions we asked, like, for example, in your opinion, to what extent does having a long-term relationship with a patient affect the following? It makes it easier to say no if the patient requests a test or procedure that I do not think that is medically indicated. Helps me discern what the patient needs and does not need in a given situation. Leads to better clinical outcomes for the patient. Makes it more enjoyable for me to see the patient. Makes the patient trust me more than he or she would otherwise. Makes the patient more likely to follow my medical recommendations. Makes patients more likely to take their medications regularly and adhere to their treatment plans. And again, these are physicians' opinions, right, about whether having long-term relationships promotes some of these patient-centered outcomes. And nationally, physicians generally perceive long-term relationships with patients to have a positive impact on clinical outcomes. We also asked in the same national survey, actually, what are the frequency in which you have meaningful long-term relations with your patients? And you can kind of see, here's the frequency. We even asked the interesting question, how many patients do you consider to be your friend? Friendships with patients, which raises a different sort of ethical and professional question there. But you'll see that most of the time, primary care physicians are having more frequent long-term relationships than with their specialist colleagues. Okay, but generally speaking, most physicians very infrequently experience meaningful long-term relationships with their patients. I should say this is sort of a personal note for me, because when I first came in to medicine, I as a medical student, I was on a longitudinal type of clerkship experience where I was following an internist in the inpatient setting and then in the outpatient setting, and actually seeing the same patient in both settings. And I thought, this is really cool. And in this case, this internist was actually, his clinic was right next to the hospital, so it made sense. And that's essentially why I came into internal medicine. Then when I came to University of Chicago, and no knock on our training, I love our training, but I was disrupted with this experience of I'm caring for patients in the hospital who don't have primary care doctors, and I couldn't have them follow up in my clinic. And that was a very demoralizing experience. So anyway, with that experience in mind, this is kind of shaping this idea of wanting to promote continuity of care, even during the training process. Because I think if you are trying to generate a pipeline of comprehensive care, primary care physicians, and in the training process, they're not experiencing that, it's unlikely that your training process is going to produce the pipeline. Right? So how at Ingalls can we generate this type of atmosphere? One proposal where we're hoping to do is, if the resident continuity clinic will be in the hospital itself, on the hospital grounds, there are ways that we can design our inpatient settings so that the residents who are on a particular team can preferentially have their continuity clinic patient still come to their team when they're on service, and be able to kind of maintain the continuity care. It's sort of like a CCP-like situation. And so this is what's kind of being planned. And I actually, we have a family medicine residency program that will also have their own service, and they will hopefully be able to care for their patients in both the inpatient and outpatient setting. So my main question for you all, given the expertise in the room, is if you had a chance to build an internal medicine residency program from scratch and wanted to integrate a comprehensive care model into the training program, how would you do it? And it seems like this would be the group for me to learn from. Okay? All right, that's all I have.
Hey, well, those were all great presentations, and I have my own list of questions, but I'm going to get to ask them anyway sooner or later. So I want to just turn it right over to the audience, and see if there's anyone. John's got a question up here, so hands are up.
I do have a question. So yesterday we had a lot of conversations about like executive buy-ins, all that. Do you think these skills of like, how do we demonstrate the value of like comprehensive care be part of education? And we're talking about like with data analytics. It's not as relevant. And I'm really curious because like, when I look at my, my past, I think, I had to focus on my clinical learning first and then add on these other things eventually through my career. So I think I think, I don't know if it's going to be too overwhelming to cram too many things. And really you want to focus on building that right culture and mindset first and eventually add those topics on much later in your career.
I can comment on that. So that is a very traditional question that we get oftentimes is like, especially when we're asking our students to be more expansive in their history taking, right? Is it too much to ask them not just to learn this biomedical concepts, but to add on, questions about their home environment, about their relationships, about their function? Is that going to overwhelm them? And I think providing that scaffolding early is important because if it's not part of the scaffolding, then it's not even in the mindset, right? So I think it's really important. And then I think providing focused opportunities to practice those skills in isolation are helpful. So actually, one of our colleagues, Dr. Aldrich, started a program called Visit. And it focuses on basically working with an admitted patient who may have some discharge barriers. So specifically, we have them do the components of the H&P 360, not the biomedical part. They're going to do all the parts that are not part of the traditional H&P to practice and focus on skills. They're going to have time to do it. Then they're paired with an interprofessional team, care managers, to really go through and discuss how can we address these issues. So it's not having them do everything at once, but practicing that skill building, having focused opportunity, having mentorship to do it, and then just having it as a piece of what they expect to be part of their purview. Right, I think it's important early on.
Joyce, I wanted to pick up on something. So, when I was a resident at Brigham and Women's Hospital, we had this like super advanced, super complicated hemonc service. And these are people who, they've had hematologic malignancies, they've been through everything, and here they were coming. And the mortality was just unfathomable. And I remember kind of looking back at the end of my internship at the body of patients I cared for, and very few of them were alive. And in the context of that, I'm amazed how many people go into oncology. There are success stories, right? And, you got to live with them, live for them maybe. But I'm struck by your observation that one of the least positive experiences was when you couldn't actually bring it into the team and do it. But what I didn't hear in your presentation, but I think you know something about, is how that experience, what that experience is like in a model like CCP that at least is mobilizing some resources. And can you talk about sort of, is there data that helps us understand that putting a learner in an environment where what seems like impossible becomes more possible alleviates some of that loss? One thing I'm struck by, we did a lot of work a decade or more ago looking at how to promote young students' interest in careers in research. And one of the things you find is that when people enter the program, everyone's enthusiastic. And then over time, they lose enthusiasm. And the measure of success in our program was that people lost enthusiasm more slowly. and that's okay. I mean, we all die. We all eventually, give up on something, but maybe. But that is a form of success. So I'm wondering if you can talk about, like, do we have data that we can, at least slow the process of disillusionment or maybe even prevent it?
Yeah, no, that's a great question. So I think I hear a lot of different themes there, and I'm trying to figure out which to address first. So there's a couple concepts. So one is empathy, right? So empathy erodes during the course of medical school. Right? It really goes down. People start really, really high on their empathy, and it just plummets. I think there's a little bit recovery maybe towards the end of medical school, but it kind of goes down. Right, internship trough. I think you get people who really want to be, change makers at the beginning of medical school, right? People come into it wanting to do the hard work, wanting to change the culture. They want to work with underserved populations. We don't need to convince them to do that. I think they already come in wanting to do that. And I think intuitively, when the biomedical stuff is hard to learn, they already know and want to address some of these social issues that they're identifying. I think that's second nature to them. So I think it's really about not promoting that so much at the beginning, but how do we lessen the decline in those tendencies and desires over time? And I think part of it is actually when you build relationships with patients, that's powerful, right? you want them to feel better. You care about them in a different way. And I think that motivates you to want to do more. So I think, I talked a little bit about that longitudinal relationship. There is evidence from longitudinal integrated clerkships that empathy is more likely to be preserved. So that is real. Just one more comment, and happy to answer that. So then secondly, I think also, what I talked about skill building to address some of these issues is really important, right? Because we all know that when we see a problem or we ask a patient about a problem and we can't do anything about it, it feels terrible, right? There's probably data on that, but I think we all know that experience really well. So if we don't have ways to address those feelings and emotions as a part of our daily work, I think we're going to lose a lot of people. And I think that's part of primary care's problem as a whole, not just building this pipeline. I think primary care has an issue with that, and we need to address it.
Yeah, just agreeing with everything you're saying, and it as reflecting on my career as family practice with these longitudinal relationships and how did I learn that? I agree that I remember at the end of my year of internship that I didn't run to a code anymore. I was burned out, and I got there, but I was just exhausted with the every 3-day, all night call. And I don't think there was really any emotional support given to us as interns. And then I think the difference was that once I got into practice at Ingalls, I got past my residency, which was more supportive, but not great. And then the team that we had at Ingalls just helped me to know that if I did discover one of these huge obstacles in a patient's ability to participate in their healthcare, I had a team who could help me. And I think I agree that I think if you immerse these medical students and residents in that sort of a program and allow them some time just to trail around with the social worker, with the team huddles, then they see, yeah, I have an option, and I can just immediately go to that, and I don't have to spend all my angst on trying to solve it because I can't. I've got to solve their medical problem. That's my role, but I need to identify those other things, and then I can find the resources for them. So
I think that's key. Kind of pulling everything together. A lot of the medical schools now are doing this curriculum 2.0, and it's actually implementing the idea of health system science not as a third core competency, but integrated within the basic science and clinical science areas. And I think it's great. What I'm visually and hearing from the medical students whenever I'm in my interprofessional course or health system science courses is that they are developing this mindset. I think the key is how do you then continue to facilitate that through their GME process? Because that is a dichotomy in a life experience, and it's a break, it's a fracture. You're going from medical school to residency. So then how do you then curate that type of thinking the next 3 to 4 years, depending on what your training program is, so that whenever people do enter the workforce, they are primed and ready to be able to take care of a population like this.
and maybe even encourage that
Oh, yeah.
sort of a setup if their
Yeah.
facility doesn't
Yeah, so
have.
we do host a longitudinal student for their first year clinical experience, and I'm struck every year about how they share how much they value our experience versus the general primary care experience. And frequently I'll say, you don't need to do a med-rec with me because we have a pharmacist that you can learn how to do a med-rec from. Or why don't you go and shadow our social worker doing a behavioral health assessment right now? And I think those experiences probably are formative, but they haven't taken effect onto their impact yet. And I'm hopeful in 5-10 years that's what we're working for, is that they can reflect on those experiences. Because whenever you're reading these medical school applicants and residency applicants, who are you rating high? The one who created a nonprofit and helped this, this sector, and like these are the people you're accepting. You already have the soft and hard skills, and then in medical education, you beat it out of them. So how do you facilitate that continued growth over time?
I just want to comment. When I originally came up with the idea of CCP, it was literally because I had written down a mathematical model of kind of what patients need and what doctors need and putting them together. And it was in the context of that I realized that if you focused on patients at high risk of hospitalization, that you could do this. The dialectical, help me. Dialectical behavioral therapy concept is like perfectly aligned with this concept, right? Because you're recognizing that psychologically there are needs on both sides and you have to do that. So I just wanted to make that little comment. But the other thing I wanted to ask about was, and I'm thinking about, like, Nicole, the way your work continues to contribute, and Joyce, the way you've brought it into medical school. But, there's this entire spectrum of learners from, frankly, very mature physicians who may have, reached a point where they need to be reinforced, to even, I'll say college students, but even high school students who are imagining going into a caring profession and whose resilience and skills to survive in that environment is being shaped. I'm curious what the business model looks like for supporting that sort of training, and whether, like at Vanderbilt, when you teach, do you get paid? I know, Joyce, like how creative you've been in mobilizing resources and building your way into the curriculum. We have a college that sits right here with majors, which are about, building health professions. I don't think they get anything resembling this in their education. And I guess I'd love to hear, either from the panel or whoever, and either now or later, how do we get the resources so that something that seems so central to a model is not an afterthought?
So those are great questions. I think so. Nicole and we have a paper submitted on this concept. So we're fingers crossed, hopefully get some traction with that. But I think it's really spreading that message. And I think it makes intuitive sense to people in terms of the business case. I mean, I think that if you see decreased turnover, that's a really big deal, especially in this line of work. I think there probably is quite a bit of turnover. So if we see decreased staff turnover, that's a great thing. Other things to look for is just, are people leaving medicine? Are people
or are people getting into med school? Like, are they more successful? Are they not giving up? I mean, those are things colleges care about.
I mean, I think these are basic life skills that are good for anybody.
Well, yes, that's
which
the
I
other
learned from
thing.
Nicole.
Do they go into social work? Do they like it if they go into it?
I mean, you sort of alluded to this with the college, but I mean, some of these questions, makes you wonder if you need to redesign pre-med requirements, because pre-med requirements dictate the kinds of curricula that these students are going to have to be forced to take, right, in order to apply to medical school. But can there be some sort of structural change that allows students to, okay, do you really need that much organic chemistry to be a doctor? Or can they learn all the stuff that Joyce was talking about as a pre-med, I mean, and still get into medical school? I mean, that requires a higher level of sort of change.
I wholeheartedly agree. I very much think that the best physicians are ones who did not do a biochemistry major or a biology major or I just if someone says I have an English degree but I fulfilled my pre-med requisites, well, that's interesting. Why did you do that? Are you a better communicator? Are you more empathetic? Do you actually be able to piece out descriptive piece of text and then apply evidence to it? I mean, it's a completely different skill set. It's and I think that I almost wonder, like, is this why medical schools and residencies are almost valuing this like X factor of someone who had a other career and then switched into medicine because they've had this solid skill set from the real world, and they're not just stuck in an academic environment from kindergarten the whole way through medical school, because they do have the life experience. I was a waiter and bartender. I mean, I think that was one of the best experiences I ever had in being able to communicate with people. Right? It wasn't any college course. So I think there's something about this real world experience that, I mean, what we're talking about is very highly philosophical, and it talks about redesigning the entire education system in America, but
How did I want to make? When hospitalists got started at U of C, I started this thing called the Hospitalist Project, which is basically undergrads interviewing patients in the hospital and after discharge. And we've probably had, I don't know, I've been doing this a long time. 700 students go through this over the years. And, some of them are now writing R01s, many of them are clinicians. I mean, it's been this amazing experience. And, I think one of the areas we've never done everything we could do is not just to have it be a research experience, but to lean more into the clinical opportunities to be engaged. Like we do, but we could do much, much more. And I raise this because it connects to the next section. One of the things I think is just really hard is to build the research infrastructure you need in places. And one way to do it is through students. And the way to do it through students is to engage them meaningfully in things that enrich all of them. And, actually one exciting thing at Ingalls is we already have like an AmeriCorps program there. We have some people. We've been looking for the infrastructure to plug them into. But it's really interesting. I'll just share, I just learned yesterday that a program that we've run for many years probably won't be refunded because it has diversity in the title of the program. So we'll have to backfill and figure out how to make it work. But putting aside America's momentary situation, I think this is a pathway that learners can complement our generation of knowledge and where we can support learners in having these much richer experiences. Elaine's better
Can
now.
I just add on that? So I'm a dean of a school that has undergraduates, and one of the hottest areas in undergraduate is alternative pathways to med or pre-professional. BS in health sciences, which open up this ability to have a much more interdisciplinary curriculum than just, this degree. And so there may be other opportunities, particularly, I'll just say for Loyola Chicago, but the other area that's happening because of the demographic cliff hitting in the generation that's coming through college is I think more universities are opening up with partnerships and pathways. So you're talking about high school or undergraduate, but there could be other ways in which you're looking for other institutions that really emphasize empathy and really emphasize the liberal arts, et cetera. So thinking of those kinds of relationships too, I know, other universities will have, it's not to take away from how do you get into the most prestigious med schools, but it's how do you open up opportunity for those that might be studying in liberal arts or other areas. And the other thing, just to add on, if you had the magic wand, I have public health and healthcare administration. I mean, university here has outstanding business school that talks about org theory and team science. Public health is talking about upstream determinants of health. Healthcare administration is talking about a lot of these concepts of health systems and how healthcare is delivered and reimbursed. And so how can you pull in that kind of faculty expertise curriculum into the program and find ways where there's opportunity as we think about what does interprofessionalism mean beyond just the clinical encounter interprofessional, but the population health interprofessionalism.
Yeah, I'll just add at Ingalls, there are a whole series of surrounding community colleges that are tremendous opportunities to do this. The other thing I just want to say is we've had now 2 AmeriCorps programs over many, many years. And one of them we've actually managed to get funded nationally. And one idea that's occurred to me is whether we could go as a group for a national AmeriCorps program that would allow us to bring, research coordinators, frankly, to our sites everywhere. And there's a cost share required. It's not that much, but that's enough money that it could make us able to do something very large collaboratively within the context of what typical R1s can support. So anyway, stuff to think about.
I was going to comment quickly, specific to Vanderbilt, and I'm not sure about Chicago, but some of our institutions, I can say one of my frustrations there was when I was at Vanderbilt, we actually shrunk the size of our medical school. And I actually think that this is the type of place that we could double the size of our medical school, triple it. Some of our places where we have these amazing resources, of course, I'm not in that leadership, but I think we do need to look seriously at ourselves in these prestigious elite institutions of, we should be training more, not fewer. So,
well, we shrunk ours too.
And it's just
years ago.
So it's just that
but
notion of,
I agree.
Yeah.
Yeah, and particularly in areas like primary care.
yes.
Yeah.
What was the motivator for shrinking?
I think it was money. I think they offered money to train these students, and it allowed them to raise the amount of financially, decrease the amount of debt. And raise scores, and we had a dean whose slogan at one point was like "shrink to excellence."
John, I was thinking about your question about building from scratch and just like the evolution of my career, the ability to think about frameworks from social work, bringing them into and I started at Franciscan St. Margaret Health in Hammond, Indiana, which is no longer really a hospital, but worked kind of closely with Ingalls and in and around that area. And had so many mentors of social work, case management. And I know I have a lot of social work colleagues, nurse colleagues here that have done the work for a long time. I imagine Ingalls has a pretty workforce in case management, social work. And it was so valuable for me to have those experiences. And I probably knew nothing about medical training, residency training, longitudinal tracks. I think I don't know if you have stakeholders from case management or social work kind of in the pre-planning phases, but as I learned in CCP and had, physician mentors and kind of understood more about medical training and the longitudinal relationships, I could grab frameworks and put them in the setting that I was in, and then also understand medical training. And, in social work, many of us are trained kind of longitudinal, but that we have a supervisory period like a residency, but we are often seeing the same patients over time in year or 2-year internships and reflective skills and empathy. Like this is kind of the core curriculum of social work. So I don't know, you may already have this, but having some key people in the room early on for social workers and case managers to learn a little bit about what you're doing and building. I think when these learners come, it won't be so much of a like, are they going to slow me down because now they're going to shadow me all of a sudden? They're really going to be bought in, and I think they're going to understand it from their own frameworks and maybe contribute to like building out that complexity of the model and the comprehensive care. It's certainly like grew networks in my mind. So just
We're allowed to recruit you to Ingalls?
He wants to recruit you there.
bring my med peds husband.
Yeah,
Vinny would be great.
I was just gonna echo that as well. I am a founding core faculty member for the Lawndale Family Medicine residency program, and it was interesting bringing these residents in. A lot of programs that are already existing at Lawndale, and having these individuals at Lawndale be like, "Who are these residents? What are they doing? Are they really a doctor?" And I'm like, "Oh, I have no idea." But at the same time, the more opportunities we have during resident education time to bring in our social workers, to bring in our team that does home visits or mobile health visits, the hospital team, we introduce them to the different members of our partner hospitals. And it basically does what Michael was saying, where it kind of breaks down that, like, this is where the doctors sit, this is where these folks sit. And then kind of getting back to what Joyce, you're saying, I truly think when our trainees come in, they're bright-eyed and bushy-tailed and excited to really dive into addressing these social determinants of health. But as has been said, there's such a moral injury that happens when you ask the question, when you identify something truly painful, and you have that moment with the patient and you're like, I don't know what I'm going to do about this, right? But when we've been able to connect our residents with individuals at Lawndale who are like, that's all I do. This is what I live for. This is what I love to do. The residents like, hey, within this 15 to 30 minutes, I asked the question, I uncovered it. I'm now going to empower my colleague, who's also my friend, who we know. And then, yeah, it's just, it really, you can see their light, their eyes light up. They get really excited about the work. So yeah, the more collaborative teamwork early on, and I'd say early on is key, the better.
I love what you all doing at Lawndale. That's why I bring the Pritzker students over there to do tours.
Yeah.
To see how healthcare can be administered in a different way.
We also recently hired one. She's fantastic. So Pritzker grad.
You brought up a comment that I just want everyone to pause and think about. Whenever you have a learner and they ask a question of why can't this be done? There's this imagery there. What I like to do is ask them back, well, how do you think it could be done? Because that actually might be the solution.
Yeah.
They haven't had the hardships of the system brought down on them, and they actually might be illuminating to how the system can be broken down.
Mike, I have a question for you, both a little tongue in cheek. So the first one is, how in a room so small did you get the wide angle lens to sort of show up for the picture of your workroom?
Oh, so that's from the door. It's really small.
It's really small.
Yeah.
Our room is actually even smaller.
Yeah.
And I guess related.
I think I did like one of these.
Have you experimented with having people sit on each other's laps? Is that okay?
We haven't yet.
We haven't yet. Okay. But I really just want to come back to the space thing, because I said yesterday, I thought it was a uniquely University of Chicago challenge, but I know it's not.
Yeah.
I'm wondering either, with your experience or in the audience, how does one get the attention of institutional leaders to create workspace that's conducive to a productive working environment? What is has anyone had success? I will say that we are now building, I would argue, our third cancer hospital since I've been at the University of Chicago. So they know how to do it, but they seem to have secrets we don't.
It's tough. So we had a room and it didn't satisfy our needs, so we redesigned the room, right? So, which is hard because it's a small room.
Yeah.
And there's not a lot of workspace available. But the key here is to walk the Gemba. No, so and lead.
Oh, thanks.
Yeah, and lead Six Sigma, there's this idea of walking the process, right? Like you go to where the work is done and you walk it, right?
Yeah.
So what some of our leaders did whenever they were expanding hospital medicine, and we're trying to do a localization of not just our team but teams in our building, is they walked up and down the halls looking for, that's a workspace, who owns that workspace? And it's really coming to the 5 whys, why can't we have this workspace? Okay, let's figure out who, and then once you have the information, you can petition for well, I would like this workspace. So for example, on the 6th floor above us, 2 hospital medicine teams work there, right? There's a workroom that they have, but they were looking for additional workspace, and across the way is where the infectious disease team works. But we were well, why do they work there? And it turns out that they work there because 10 years ago, all the ID patients were on that floor, but now there's no ID patients on that floor. So then you would say, where are your patients? And they're all over the hospital. It's well, can we trade? Right. So I think this is just coming up with creative solutions and what are the limited resources. And if you do have a workspace, I think it's always creative to see how can you redesign that workspace to best fit your needs.
I mean,
it's really hard to do. You almost need Marie Kondo to come in.
Put everyone in a drawer.
Yeah.
Roll them. Yeah.
I just wanna encourage you guys. So the one thing that they good at Cigna was they kind of said the future of work is remote. So the good thing was I came from the mindset of Vanderbilt of this interdisciplinary thing. So I kind of transformed that mindset to how do I do it in a remote landscape. So my MA is in Idaho. My nurse coordinator is in Southern Alabama. And we make it work. It's the culture and the mindset that you have to kind of bring in. So we have like digital workspaces that we talk very regularly. So I think thinking about the future, like how can you incorporate if the future is going to be like this, how can I make them comfortable creating a team remotely, right? How do you do that? It was easier again because I had some framework, but coming out of like if you didn't have a framework, how would you do that on your own? So something to think about.
Yeah, last two questions here.
Sorry, so can I just quickly, you have a fabulous architectural program here at U Chicago. This is exactly what dissertation students are looking for is problems like this to solve.
No, that's okay. I just wanted to pivot from the limited resource of space to time. And I'm very interested in kind of these debriefing of what our team is doing. And as we're getting our team started, I think that's already starting to be kind of an underlying tone or theme of some of our weekly huddles, which we've limited to like 30 minutes right now. And even that is like pushing it in terms of being able to discuss patients. So I'm just wondering from like a practical standpoint, like, how are you introducing these debriefing? Is it like at the end of a meeting? Are you having a separate session for this? What would you suggest for someone who's just getting started with this type of thing?
That's a great question. I mean, do you want to talk about CCR?
Yeah, I think it's hard to find the time. And I think, Joyce, we've talked about like brief takeaways. I think something as simple as like some agreements, a few I talked about yesterday at the end of a meeting, or I know like Annie, like once a month. Can you start there? See how, just to frame like people bring in patient encounter. Let's talk about the work that we're doing. Let's not make this like another thing I gotta go to build my resilience. But like, could I add a few prompts of questions or dilemmas? This came up for me. It helps to have a framework, or it helps to have something to like chew on. I feel like we do it twice a week. We've embedded it in our social service team workflow. We onboard with it. It's become really part of our culture, but it started as like an MDR.
Yeah.
And now it's evolved. We still care coordinate. We talk about patient care, but like there is this, like it snuck in.
Yeah.
The vegetables are snuck in.
Yeah, no, it's very quickly like, and I just don't want it to lose all these great people that we've already.
Glad to talk more offline, but I think there's phases, stages, ways to modify.
Little ways to build it in, I mean, I think you even role modeling that in the discussion, right? You're talking about a case and this is how I felt about it. And, what are other people thinking? Or I feel like I need some support around X, I'm feeling really down about the way I approach the situation, or self-disclosure and setting that culture and tone that's okay to feel that way, that kind of just introduces those frameworks, I think.
We've reached time, so we've got a 15-minute break. Let's leave this slide up to remind everyone to tell John how to design the residency program. Thanks for a great session, and we'll